All right, we're going to get started. My name is Dr. Todd Haber. I was an alumnus here. I did IM from 84 to 87. That's where all the endocrine stuff came. And then EM from 1987 to 90, right in this very building. So I love this place. This place still has my heart and soul. You're blessed to be here. Enjoy it and relish it. Anyway, so today we're going to talk about EKGs. And when you think about academic medicine and EKGs, who do you think of? You think of a mama too. Well, Todd, he's too expensive. You can't get him. So but I met Amal at the ASAP Teaching Fellowship 4 years ago, and my teaching vibes got rejuvenated, and I sort of been an EKG disciple. So the hardest thing about this lecture is to talk about EKGs, things I've learned from him, and not sound like him. So I'm going to try my best not to be his mini. ST elevations. This is emergency medicine where the rubber hits the road. You've got to get this right. I'll put this out for the attendings and the senior residents. How many of you have sent a patient to the cath lab and it was negative? How many people did not send a person to the cath lab and on retrospect said, there may have been a STEMI? Come on. I'm not talking about 100% occlusion as a normal EKG. I'm talking about someone you didn't send and on retrospect, maybe I missed that one. Anybody? Okay. I'm not sure I buy that, but that's all right. Okay, but we're going to talk about ST elevations versus mimics, because not all ST elevations are STEMIs. So we have to be very careful about this. What do we want to do? We want to avoid STEMI misses, because time is money, and 25% of all malpractice dollars against us is from missed ACS, STEMIs, unstable angina. This is a big one. Time is muscle, so you don't want to miss STEMIs. On the other hand, you don't want to send people to the cath lab and have it be negative, because the studies show those people do worse. There's the risk of a cath, and you're delaying the search for the real killer. And if you activate your cath lab in the community, and you call your cardiologist, you're going to piss them off at 3 o'clock. When you go out to the real world, activate STEMI a couple times, have the cardiologist come in for pericarditis and do a cath and it's negative, it's not going to go well. So we got to get this right. We want to bring our sensitivity and specificity as close to 100% as possible. Am I 100%? No. Have I made mistakes? Yes. Some of the cases in there, I messed up. So we're going to go over all this stuff. Got to give some kudos and props. Life in the Fast Lane is a great EKG website. Got some great imaging. I stole some of them. ECGweekly.com, that's Amal's website. You can use the Haber 16 promo. It takes your price down from $26 to $15. Once a week case. I'm putting in a plug for Amal. It's fabulous. I've sent him 28 cases in the last 3.5 years of his website. ECG Weekly is the little website that could. And I give props to Amal for helping me with this. We're going to play a game here. That's why you all have your cards. It's 4 a.m. Do you wake up the cardiologist? 4 tough cases. Play along with your handouts. I will tell you that I was only 75% on this. I messed up one. And we'll go through it. So these are tough cases. Case number 1, a 28-year-old smoking male with a little bit of burning in his chest and a tightness. Pain has a pleuritic component. Look at your EKG and give me a yes on the white card or a no on the blue card if you activate the cath lab on this EKG. Anybody activating? Anybody not activating? Everybody, give me a white or a blue card. I got a blue card. I got a lot of no's. Any yeses? A lot of no's so far. How about if I got a thumbs down? How about if I told you the troponin was 8? Would that change anybody's activation? Point of care troponin, still no. Okay, good. 72-year-old female, post-cardiac arrest. Real case, I saw. 72-year-old female. It's a crappy reproduction, and I apologize for this. It's on your sheet to get a little bit better. 72-year-old female who 5 weeks ago had resection of a malignant, quote-unquote, meningioma in her brain, progressively short of breath at home, and stopped breathing right in front of me, and went to cardiac arrest. 1 round of CPR, epi, and intubation. This was an EKG post-regaining circulation. You can look at it closely. There's some ST elevations in 3.5, some reciprocals in 1 and L, and some other things. Who would activate the cath lab on this? Any yeses? I got a thumbs up back there. Oh, cripples are fine. This was a witness arrest, came right back. She had, on the post-cardiac cardiac arrest, she had full recovery. She was pulling her endotracheus, but her arrest lasted 3 minutes. What's that? We'll talk about the bedside echo when we go over the case. But yes, I did a bedside echo. Anyone activate? I got some yeses. Any no's? Aye.
What was the rhythm on the arrest?
This is a sinus tap.
No. The arrest was a...
The arrest was a PA asystole arrest. It was not a VTIV arrest. Good point. I did not shock her. She responded to CPR, epinephrine, then intubation. As it came back before intubation. This is EKG of the sinus tap. I got some yes. I activated on this one. We'll go over it. 66-year-old male, crushing subdural chest pain with sweatiness. Who would activate? Got some thumbs up. Any no's? Any no's? Okay, we'll go over that next. 57-year-old female, 1 hour of chest pain. Who activates? Any activations? Got some yeses. Any no's? What's that? You pass? Okay. Oh, I'm sorry. You want to go back to the previous one or just look at this one? Take a second look at it. Now, one no, one brave soul says no. I got a bunch of yeses. I got thumbs up in the back. Any other no's? Okay, we'll go over it. I'm rushing a little bit. I got another no in the back. So we'll go over this in a little bit, and I'll tell you when we go over it. 2 are STEMIs, 2 aren't of the 4 cases. Let's go over it. So now, how to read an EKG in 30 seconds or less. An ECG is a test. As we learned previously, we don't get the ECG on every single first case we had a follow-up round. We didn't need an ECG. If I stub my toe, I don't need an ECG. You have to suspect something. So it's still history before we order any test. And once you have a history, you have to have a clinical question that the EKG can answer. To make this short, I'll give you the 3 questions of ECG. Does the patient have blank? Does the patient have ischemic heart disease? That's what the question we answer with an EKG. Question number 1. Question number 2, what is the blank? What is the rhythm? And then 3 is miscellaneous. We're looking for clues for other illness. We're looking for toxicology, hyperkalemia, so and so. So 3 questions. Does the patient have ACS? What is the rhythm? And clues to miscellaneous other stuff. Why we get an EKG. It's like anything else in medicine. A systematic read. Have a system. Rate, rhythm, axis, intervals, ischemia, enlargement, hypertrophy. Just go down to systematic. The mistake we make on EKGs is we jump to the first thing that looks abnormal. It's pattern recognition, and it's going to lead to errors. Systematic, every time we'll go over that. Since this is a talk on ischemia, we're going to skip to ischemia. What do you look for in ischemia? Q waves, depth and width, T waves, amplitude, polarity, and shape, ST segments. And it's important with the ST segments when we talk about elevation or depression, the baseline is the next TP segment, not the previous PR. And you have STE, STD, that's not chlamydia. You have shape and slope. So ST, those are the 3 aspects of ischemia. When you're answering the question, does this patient have ACS? And remember, 25% of malpractice dollars are based on missed ACS. And Amal says he does medical legal. 50% of the cases he reviewed, the EKG is not arguable. He cannot defend the ED position because we're clearly abnormalities. So just like DKA is our baby, ischemia is our baby. You see the patient with the active chest pain. Anyway, we're talking about STEMI versus mimic. So let's look at our STEMI criteria. We measure ST segments at the J point. That's where the QRS ends and the ST begins. It's where the thing changes shape. It's often hard to see. So this is your American College of Cardiology new criteria, so ACC guidelines. J point elevation greater than 1 in 2 contiguous leads, except for V2 and V3, where it can be higher. Over 2.5 in males less than 40, over 2 in males over 40, 1.5 in females. STEs in STEMI can be any morphology, concave, horizontal, or convex. And 30% of STEMIs do not have reciprocal changes. Never, ever, ever say, in the face of concerning history, an ST elevation, well, sorry, Charlie, you don't have reciprocal depression. This can't be a STEMI. Can't do that. 30% of STEMIs do not have reciprocal changes. So here are the mimics. On the left, I put the bad ones, the major ones, the ones we find out all the time. On the right are some of the minor ones. You don't really have to worry that much about the minor ones. Brugada doesn't present with chest pain, it presents with syncope. Hypothermia, as Amal says, if you're diagnosing hypothermia on an EKG, you have a triage problem. Use a thermometer. Takasobo should probably move over to the left, but it's in common. Intracranial hemorrhage. Yes, go ahead. What's that? On the bottom? PE? Oh, benign early repolarization. And PE's on the bottom. Intracranial hemorrhage. If you have someone who collapsed, comatose, you intubate, and have a grossly abnormal EKG, yeah, it could still be a STEMI, but it also could be a bleed in the head. Hyperkalemia can do it, but those people are not usually having chest pain. The ones on the left are the ones we're going to go over. Pericarditis, benign LV aneurysm, left bundle, LVH, hyperkalemia, and PE. Anyone want to take a guess of the ones on the left? Which one is the most common cause of a false tablet activation? It's almost impossible to determine. It's LVH. There's no algorithm that completely determines STEMI versus LVH. LVH is the trickiest one of all. So let's look at pericarditis. Again, it's history. Younger person, pain tends to get better when you lean forward, usually after an upper respiratory illness. Not always, but history. When you do it, you have to have a pretest probability of what you're looking for. In pericarditis, the STEs are diffuse, non-anatomical, like a STEMI. They're always concave up. If they're horizontal and convex, it excludes pericarditis. Not myocarditis, but pericarditis. Here's the trap. PR depressions are unreliable. You get them in pericarditis. You get them in STEMIs. You don't get them in pericarditis. So you can't look at an EKG and say, bam, PR depressions, it's pericarditis. PR elevation and AVR are the same thing. In pericarditis, there are no reciprocal depressions. This is what pericarditis looks like. Concave elevations everywhere, usually greater than 2 than at least 3. No reciprocal depressions, always concave. PR depression, they're variable in pericarditis. They're not sensitive to pericarditis, they're only seen in viral. So if you don't see PR depression, it doesn't mean it's not pericarditis. They can also be seen in STEMIs. It's not specific for pericarditis. Same thing for PR elevations. So how do you tell the difference in the diagnosis of pericarditis versus STEMI? You look at the EKG, and there's 4 things that would suggest STEMI. And have reciprocal depressions, done. Pericarditis does not do that. If the EKG shows horizontal or convex ST elevations, done. If 3 is greater than 2, done, STEMI. And if there are new Q waves, that's harder. If all those are negative, and it's not a STEMI, then you move on to step 2. Are there PR depressions? If there's PR depression and the lack of the other 4 rule-ins for STEMI, then there's a good chance it could be pericarditis. And the other thing is called a spottic sign. If you look at the TP segment, it slopes downward. So before you even look for PR depression, you've got to do the 4 STEMI rule-outs. Reciprocal depressions, shape of the ST, 3 greater than 2, and new Q waves. And in myocarditis, all bets are off. Myocarditis versus STEMI, almost impossible. Benign early recall. The good news of these, and we see these all the time, and usually when we get an EKG for some bullshit reason, they have lower abdominal pain, and we didn't unclick the EKG off the power plant. So usually in BER we get lucky, and the symptoms aren't concerning. It's a normal variant under the age of 50. The ST elevations are concave, just like pericarditis. 2 is greater than 3, just like pericarditis. There's usually that notching at the J point. In STE, the V6 is usually less than 25% of the height in the T wave. There are no reciprocal changes, and the EKG doesn't evolve. So if you're going BER versus STEMI, it's the same 4 criteria. If you see reciprocal depressions, it's not BER. If you see horizontal or convex, it's not BER. If 3 is greater than 2, it is not BER. And all of these things, because I'm an ultrasound guy, if you're really good with cardiac echo, you can look for wall motion abnormalities. And we're going to talk about that from one of the cardiac arrests. Here's what BER looks like. You can see this ST elevation, but it's all concave. You can see, where's the little, you can see a little fish up there, and look at the side, the ST elevation V6 is less than 25% of the height of the T wave. LV aneurysm. These are the ones that usually come up like pre-op, from orthopedic case, and you see deep Q waves and ST elevations. In LV aneurysm, you get persistent ST elevations, but they can be any shape. So it can look like a STEMI. You usually get large Qs. The good news is these patients don't have active chest pain or anginal symptoms. The best way to determine this is get an old EKG. You guys have access on EMR to get old EKGs? You see any patient with chest pain or anything, hit that computer, see if you can print up an old EKG. That's one of the benefits. We used to wait for Ella to come around with the box of old records for medical records an hour and a half. So our turnaround time in 1987 on EKGs was about 90 minutes. Now it should be 90 seconds. LV aneurysm versus STEMI. This is what LV aneurysm looks like. These can look like STEMIs. That one in V2, that's a horizontal. That's a tough one. If they're having active chest pain and it sounds like a STEMI, you might get hosed. This may be a cause of a false negative cath lab activation. This is the tricky one, LVH. These are really tough. LVH has increased R waves in the lateral leads, increased S wave in the right-sided leads. Your QRS gets prolonged. You get ST elevations of V1 through V3 of any shape, and you get STDs in the lateral leads. And there's no algorithm that tells you the difference. Old EKGs are incredibly helpful, but the formula for pericarditis does not work here. Some things that LVH, but here's the good news. In order to have LVH, you got to have LVH. So they've got to meet the voltage and the other criteria for LVH. If they don't meet that, then it's not LVH, then it's a STEMI. And it's three-pronged scoring system for LVH. You get a point for left atrial enlargement. You get changed for the voltage criteria, which I'm not going to bash it over your heads. You know what it is. And you get a point for the strain power. So if it doesn't look like this, LVH based on this stuff, then it's a STEMI. Because you can't say it's LVH if there's no LVH. Just like you can't have a STEMI without the STAT. Here's what LVH looks like. You got elevations V1 through V3. You got depressions in the lateral leads. You don't really see much of the left atrial enlargement on this one. But anyway, it's the toughest call. The hardest call. I sent LVH to the cath lab. Clinical history always helps you. What is your pre-test probability of the illness that you're looking for? If it's a classic story, you've got LVH and you don't have all the EKGs, you may be stuck. But here are some of the things that look like it. Favor STEMI. Excessive disconcordance. In the septal leads, where the S wave goes down, if the STs go up greater than 25% of the height, sort of a modified Scarbosa, which we're going to talk about, that favors STEMI. If the ST segments are horizontal, if the ST segment depressions laterally are horizontal or upsloping, usually if that strain pattern is this, if it looks like this or this, but still goes down, that's more concerning for STEMI. Symmetric T-wave inversions laterally, as opposed to, if it's symmetric, that goes more for STEMI, but nothing is 100%. It's the most common cause of false activation, but it can't be LVH without LVH. Left bundle branch block. This is tough. We used to call STEMIs on all new left bundles, or presumed to. That's out. Left bundles are prolonged QRS, large monophasic S and V1, or small R wave. Monophasic upright leads, R waves, 1L, V4 through V6. And with left bundles, you have discordant ST elevation depression. Basically, the rule of thumb for left bundle, if the QRS goes up, the STs go down. If the QRSs go down, the STs go up. With elevation depression, that's normal. So if you look at a left bundle, and in every lead, the ST segments are opposite the QRS, that's appropriate disconcordance. That is normal. Here's what a left bundle looks like. Look at leads 1L and V6. QRS up, STs down. Look at the septal lead. Small R, big S, V1, V3 up. Normal. Tough call in the face of active chest pain. Here's your Scarbosa criteria. On the left screen, your left, is Scarbosa A. Greater than 1 millimeter of concordant ST elevation. The ST elevations are in the same direction in any lead. On the screen right is Scarbosa B. In V1, V2, or V3, 1 millimeter of ST depression concordant in the same direction. That's Scarbosa. This is on your board. I'm giving you, the residents of the in-service, I'm giving you a free point on your in-service. Please take it. Please. And Scarbosa C is in the middle, but they've modified this. It used to be greater than 5 millimeters of excessive disconcordance. Now it's a ratio. In other words, if the ST elevations are greater than 25% of the QRS in the opposite direction, that's Scarbosa C modified at Smith's criteria. And by the way, have you guys ever heard of Steve Smith? He's a guy out of Hennepin County in Minnesota. He's got like an awesomest blog. He writes it in hieroglyphics in Greek. I'm pretty good at EKGs, and I have a hard time understanding it, but he's really got a lot of good information in it. Not quite as good as ECG Weekly, but it's high-tech stuff, and he's pretty good. But those are the Scarbosa criteria. This is a Mama 2's whiteboard. He does teaching rounds in his hospital. He has a little whiteboard, and I'll send anyone these slides. Basically, how it has STEMI, pericarditis, benign or what we call aneurysms, and he goes to a little thing, a little checklist. I will send you these slides, anyone who wants it. Actually, I'll send it to the chiefs. You guys have it already. Anyone who wants it, just come see me. We're not going to redo the lecture. Pulmonary embolism, another mimic, as we're going to see later on. Sinus tach, this S1Q3 T3 is not sensitive or specific for your boards. You get a right axis deviation in these if you're having right heart strain. STEMIs very rarely produce right axis deviation. Only laterals with Qs at least 1L will do it if it's old. So if you see a right axis deviation and you think it's a STEMI, think again. Very rare for an acute STEMI, but that's why you have to do rate, rhythm, axis. If you go right to the ST elevations, you're going to miss the right axis. If you have a right axis and STEMI-like changes, think pulmonary embolism and hyperkalemia, like the EKG we saw in follow-up rounds. Pulmonary embolism can also cause ST elevation, depression, and flip T waves in the inferolateral leads. Flip T waves inferolaterally according to Henry Marriott, Amal, and all the other people is P until proven otherwise. Here's what it looks like. You can see lead 1 is you have a rightward axis. You've got some flip T waves in the infraset. This doesn't have much in the way of ST elevation. Hyperkalemia. We all know about the peak T waves, the widen QRS, the prolonged QR, and the flat loss. Everyone knows about that. Nobody knows about the AV blocks, the bundle branch patterns, the pseudo-ACS, because ST elevations in the septal leads, ST depressions in the inferior leads. And it also causes the right axis deviation. The EKG we saw after the patient with adrenal insufficiency coded looked like this, also had a right axis deviation. This is what hyperkalemia looks like. This is what Brugada looks like. We're not going to make this a discussion of Brugada. This is what the roller coaster T waves of a bleed in the head look like. This can mimic ischemia too. Here's what hypothermia looks like. If you're diagnosing this on an EKG, you have a triage problem, use a thermometer. Okay, let's get back to our cases. 28-year-old male, chest pain, smoker, had a little bit of a viral illness. There was a fluoritic component to this. What do we notice on this EKG? Anyone want to play? Who do I hate? All right, in the interest of speed, we'll let everyone stumble through. We see diffuse ST elevations. Non-anatomical leads. With the history, what's our differential? Pericarditis/myocarditis versus STEMI. So let's go to our algorithm. We have ST elevations. Are there any reciprocal depressions? No. The shape is concave. No horizontal or convex. No. Is 3 greater than 2? Actually, 2 is greater than 3, so no. Do we see any Q waves? No. So what is this? We can look for PR depressions, but we don't really see any. So you're stuck. But you have no evidence of a STEMI. Your history is not really STEMI-like. So this is probably pericarditis, but there's a kicker in it. If you look out here, the R wave voltage low here is low, and the T waves are of higher amplitude than the QRS. That's concerning. The other thing that happened with patients, the point of care component came back at 8. You can activate them. Your EKG still looks like pericarditis. You have a component of 8, and you have some elevated T-wave morphology higher than the QRS amplitude in B4 and B5. So you have some evidence of ischemia. Well, it turned out we did not activate. This turned out to be myocarditis, the troponin of 8. This patient did fine with anti-inflammatories, some steroids, and blah, blah, blah. The troponin of 8, though, takes some balls. You get a POC troponin, you got an 8, you sit on it, it takes some cojones. This is the case, get some cardiology input in. I'm not saying activate the catheter, but talk to somebody about this. If you just sit on this by yourself and something happens, this is a problem. So anyway, this patient did not have a STEMI. So for those that did not activate, well done. This is my case. And of course, they're always the mother of one of your unit clerks. Always. So this lady came in, we'll talk about the point of care ultrasound. This lady came in, She's 5 weeks post-brain surgery, progressive shortness of breath. She stopped breathing, and it was a PEA gravity. It was not a V-fib arrest, as you mentioned. When I put the ultrasound on her during the initial thing, her RV looked ginormous. We resuscitated her. We got this EKG. So what do we find? There's some subtle findings. It's a crappy, and I apologize. And I had an old EKG that I should have included. First of all, she's got a sinus tach. Second of all, she's got a smidge of a rightward axis that's new. The R wave, you have an R wave, you have an S wave in one, which she didn't have before. The QRS is a little bit wider than the baseline. But she has ST elevations and 3.5 reciprocal depressions. So what's the differential here? PE versus what? P versus STEMI. I mean, this could still be an empirical STEMI. I had a floppy, not moving dilated RV on ultrasound, which you get on a STEMI. Let's say the patient's unstable. What could you treat her with? What treats both? It does, but she just had a malignant brain tumor yanked out of her head 5 weeks ago. So that makes it problematic. So what do you do? Well, she's not arrested anymore. I resuscitated. Now she's got ROS, she has normal blood pressure. She's about 100. What do you do? I did get an ODPG. There was no S wave in one. The QRS was narrower. There was no ST elevation. I was reasonably thinking about PE here. I spoke to my cardiologist. So I can't just give her TPA. I can't even send her interventional. So I did activate this one. I took it with a plan. I said, if it's not a STEMI, we're going to take her back. We're going to scan her chest. I considered taking her to the CAT scanner first and scanning her chest, but she hasn't really lost the pressure on. I had an unstable patient. Yeah, I'm in a crap ball. I'm in a world of hurt here. If I send her to CT, she codes again, I miss the STEMI, I'm screwed. If I take it at the cath lab and it's a PE, I'm screwed. We took it to the cath lab. It was clean. We took her right back down and scanned her chest. She had a big PE, of course. She went to interventional. They did not give her catheter-guided lytics. They just did an embolectomy. They did a dry embolectomy. They didn't do something. Go ahead.
Actually, it's not funny. So I actually had
It wasn't funny when I was dealing with it, but it is.
So I actually had this both of these first things and like first things. It's on the
Yeah.
And I was like, secondly, he basically said this was it was actually like we were right.
Yeah, I mean, the key, yes, did I activate incorrectly? Yes, but not blindly. The problem when you activate incorrectly, go off from that. Remember, the cardiologist is just answering one question. Is there a STEMI? Is there a otherwise, see ya, I'm done. Off to the internal medicine floor or wherever they go. I had enough on this one. If that cath is negative, you send the report right back down to me. And of course, I've got the family, which is getting larger by the minute. Dr. Hager's got to do something. I've watched it for 25 years. Please save her. Anyway, we did. She survived her event, got an embolectomy. It's a pretty amazing case, actually. Okay, case number 3. Who activated? I think a lot of people. Did anyone not activate? In the interest of speed, this is Scarbosa A. It's a left bundle. We get elevations here. Whoops. Let's see. We'll get. I'll do it quickly. Okay, here we are. It's a Scarbosa A inferior wall. The concord and ST elevation is 3.5. It's Scarbosa A. This patient had 100% RCA. Whoever activated here, kudos. Whoever didn't activate, wah wah. Number 4, a couple did not activate here. What do you see on the EKG? You see a right bundle branch block. And you also see elevations in 2, 3.5. Does the right bundle affect your ST segments? Yes, you get some depressions in V1, V2, V3, but if you see elevation in the right bundle, it's a STEMI. Right bundle does not cause ST elevation. This was an acute coronary occlusion. So take-home points. Ooh, I am catching you up. Take-home points. History. See the patient. Pre-test probability of the 3 questions you want to answer with an EKG. What is my pre-test probability of ACS? What's the rhythm? And do I need an EKG to look for something else? Hyperkalemia, what are the intervals, blah, blah, blah. Systematic EKG read, rate, rhythm, axis, ischemia, enlargement, hypertrophy. Don't just jump to the ST elevation. If you do that, you'll miss the right axis deviation. You'll miss the prolongation of the QRS. You can always rule in STEMI, can never rule out a STEMI. Anything can still be a STEMI. PR depressions are not sensitive or specific for pericarditis. Do not look at an EKG and say, aha, PR depression, it's pericarditis. What's the most important EKG? The old EKG. What's the next most important EKG? The next EKG. Corey Slovis, one EKG begets another. Keep getting them. Piss off your nurses. Go ahead, more EKGs. And most important of all, practice, 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 practice. And then, when you're really bored, practice some more.